A very good afternoon to one and all. Today, we shall be discussing sleep disorders, primarily their classification and identification of sleep disorders and management of sleep disorders in brief. I am Dr. Lakshmi Nirisha. I am Assistant Professor of Psychiatry here at NIMHANS, Bangalore. So the outline of our today's presentation would be divided into two main parts, wherein in part one, we shall briefly discuss introduction to sleep physiology, and subsequently we shall discuss classification of sleep disorders, the various classifications, which is Diagnostic Statistical Manual of DSM-5, then International Classification of Sleep Disorders, 3rd edition, and ICD, that is International Classification of Diseases, 10th edition, which is formulated by the World Health Organization. And in part one, lastly, we shall discuss the detailed clinical presentations of various sleep disorders, keeping the DSM-5 as the basis. In part two, we shall discuss evaluation for sleep disorders and management of sleep disorders. Now, first coming to what is actually sleep. So before we move on to what sleep disorders really are, I think it's important that we relook at and revise what exactly sleep is. Sleep is actually a recurring physiological state which is characterized by altered consciousness, reduced perception of environmental stimuli, and inhibition of most voluntary muscles. So basically, this is a normal physiological phenomenon wherein the consciousness is altered. That is, the person is either responds very little to outside the stimuli, is semi-conscious or unconscious, and his muscle movement, that is, his muscles totally are rested and they do not show any voluntary movement. On an average, an individual spends about 1/3 of his life sleeping, and sleep is required for proper brain function. And as we know, sleep is not just a single process, but it has several distinct types of sleep types are there, and there are multiple processes that go on during the sleep. Sleep is not a passive process, but it is actually a high degree of brain activation and metabolism occurs during sleep. Now, let's briefly look at the sleep physiology before we go on to sleep disorders. As we all know, sleep has multiple stages. The first stage is basically being awake. Before a person falls asleep, he's awake, he's conscious, he's responding to the external stimuli. And then he moves on to the sleep stages. First, usually, as soon as a person attempts to go to sleep, he goes into something called as a non-rapid eye movement sleep stage. In this stage, again, further is divided into N1, N2, and N3. In N1 is basically, it's an initiation where the person starts becoming drowsy. He starts feeling tired and he would wish to go to sleep. In N2, this process becomes more strong, wherein the body starts relaxing, heart rate reduces, the muscles become more and more relaxed, and the person is now ready to fall into deep sleep, which is the N3. N3 is basically where the person is totally shut off from the external stimuli. He goes into what we say as deep sleep. So this, on an average, goes on for about half of the sleep cycle. What we say, when the whole REM and NREM we take, it comes across as one sleep cycle. So subsequently, the individual goes into what is a REM stage of sleep. REM is nothing but rapid eye movement sleep stage, which actually involves wherein the person is almost like awake, but in his sleep. His brain is continuously active. There are dreams that we remember occur during REM sleep disturbances. There are some motor activity that sometimes does occur in REM sleep stage. And this whole one cycle goes on to about 90 to 120 minutes. And an individual, if we take about 7 hours of sleep, that has been shown in this hypnogram of a normal sleep, in the 7-hour period, an individual goes through at least 4 to 5 cycles during this whole night sleep. So like we see here, 7 hours is what is the median, is the mean duration of a good sleep. Good sleep is what is said. Anything less than that is considered to be decreased sleep. Yes. Now moving on to the sleep disorders per se. Before that, a couple of points. The stages of sleep that I've described here is basically an adult sleep. But in children and in elderly, these sleep stages and the duration of the cycles vary. For example, children, newborns have very short cycles. So that is why we often notice that children wake up frequently when they are small and they require frequent attentions. But as they grow older, the sleep cycle duration increases, and subsequently their undisturbed sleep duration also increases with time. And coming to the elderly, as we grow older, the sleep cycles again shorten, and therefore most of the time elderly experience less shorter duration of sleep because of shorter cycles. Now coming to the classification of sleep disorders. Sleep disorders are primarily classified on three different basically characteristics. One is disorders causing difficulty in nighttime sleep. That is, a person goes to sleep and what exactly happens, disorders during that happen during that nighttime sleep. Disorders causing daytime sleepiness. As we discussed, sleep is expected to happen during the night, but here in these set of disorders, there is daytime sleepiness. Third group of disorders is disorders causing abnormal behaviors during the night. So now coming to the classificatory systems. Earlier, there was no systematic way of identifying or classifying, diagnosing a particular sleep disorder. So that is when the classificatory systems came into play. So basically, what are the advantages of these classificatory systems? So basically, they standardize the definitions. One uniform definition is used by all professionals. It also increases awareness of conditions among professionals. Many of them are often unaware of different types of sleep disorders. So having a good classificatory system with all the disorders under one classificatory system increases the knowledge of a professional, enables formulating differential diagnosis, and thus ultimately helps us come up with a standardized diagnostic approach and treatment of sleep disorders. This again enables us to provide medications or any other interventions for a sleep disorder in a more standardized way, so that the individual or the patient does not have to go through non-standardized treatment procedures or medications which may not be efficacious and because of a wrong diagnosis. Now coming to the different types of sleep disorders. So first is the Diagnostic and Statistical Manual of Mental Disorders, that is DSM-5, which is currently in its 5th edition. The next is the International Classification of Sleep Disorders, which is currently 3rd edition. So earlier for DSM-5 is primarily used by psychiatrists and at times other medical professionals also. ICSD was actually initiated by sleep professionals, wherein initially it was thought of that there is no standardized classifications, therefore research and other aspects were very difficult. So therefore the ICSD came across, and then this has undergone multiple revisions, and now it is in its 3rd editions, which came up in 2014. Lastly, currently the oldest of the classificatory systems that is available for sleep disorders is ICD-10, which is formulated by the World Health Organizations. So basically this was ICD is meant for primary care professionals all over the world for easy accessibility and diagnosis of clinical conditions. And this was formulated way back in 1997. As you can see, in comparison to the other two classificatory systems, it is quite old. So therefore, today we will not be discussing about ICD-10 classificatory system. Coming to DSM-5 classification. DSM-5 basically describes sleep disorders as sleep-wake disorders. Like we discussed earlier, sleep disorders are not just about the nighttime sleep, but it is also about the wakeful time, that is the daytime. And totally around 11 broad categories have been described. And as mentioned earlier, it is primarily used by psychiatrists and other medical professionals. And it is more oriented towards clinical diagnosis rather than research. it gives clear descriptions about the disorders and the different types of disorders that come across in each group. So what are these 11 broad categories? First is the insomnia disorders, hypersomnolence disorder or hypersomnia, narcolepsy or hypocretin deficiency disorder, obstructive sleep apnea, central sleep apnea, sleep-related hypoventilation, circadian rhythm sleep-wake disorder, disorders of arousal, nightmare disorders, rapid eye movement sleep behavioral disorder, and finally the restless leg syndrome. Next, coming to the ICSD-3 classification of sleep disorders. ICSD third edition includes 7 major categories of sleep disorders. It is used by sleep specialists and for research purposes. The primary classifications described here are: first is insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, sleep-related movement disorders, and other sleep disorders. Like you can see, DSM-5 and ICSD have almost similar classifications, a similar set of disorders, but terminologies may differ. For example, here in DSM-5, we do not have parasomnias as a separate broad category, but nightmare disorders, rapid eye movement disorders come under parasomnias, which is classified as a separate category in ICSD. So lastly, the International Classification of Diseases, 10th edition. G47 is the code wherein sleep disorders are described. In addition, psychiatric disorders are also quite often seen with sleep disorders. So certain disorders are classified under mental and behavioral disorders of ICD-10. So insomnia is G47, hypersomnia G4710, circadian rhythm sleep disorders G4720, sleepwalking, which is a parasomnia, comes under F51, which comes under mental and behavioral disorders. Night terrors comes under F51.4, again comes under mental and behavioral disorders of ICD. REM sleep behavioral disorder comes again under sleep disorder of G47 category. And then lastly, obstructive sleep apnea, which is G47.33. I have not described every disorder that and all its codes. I've taken the most common or the commonalities between the 3 classifications for better understanding and assimilation. So moving forward, for the purpose of understanding the various sleep-wake disorders, DSM-5 criteria is used for discussing the clinical presentations and the diagnosis. So taking all the 3 classificatory systems for the purpose of our presentation today, we shall broadly discuss the DSM-5 disorders under the 7 categories. That is insomnia, hypersomnolence, narcolepsy, breathing related sleep disorders, circadian rhythm sleep disorders, parasomnias, and movement related sleep disorders. So insomnia and hypersomnolence, they basically a single group of disorders in their each category. Narcolepsy includes narcolepsy and hypocretin deficiency. Breathing related sleep disorders include OSA, that is obstructive sleep apnea, central sleep apnea, and sleep related hypoventilation. Circadian rhythm sleep disorders, basically which are disorders of arousal and wakefulness. These include delayed sleep phase type, advanced sleep phase type, irregular sleep wake type, non-24 sleep wake type, and shift work sleep wake type. In circadian rhythm sleep disorders, these are basically acquired or wherein an individual sleep pattern is influences the onset of these disorders. It is not due to any inherent or any medical condition. Parasomnias include sleepwalking, night terrors, nightmares, and rapid eye movement behavioral disorders, in short called as REM-BD. Lastly, movement-related sleep disorders, which includes the restless leg syndrome and periodic limb movement disorder, PLM-ND in short. Now first coming to insomnia. Insomnia originates from a Latin word which is somnus, which actually means sleep, and insomnus, which means sleeplessness. So insomnia is a disorder characterized by difficulty in falling asleep, staying asleep, waking up earlier than desired, and inability to fall back in sleep. That is, it includes difficulty in initiating sleep, that is falling asleep, and difficulty in maintaining sleep. That is, once a person falls asleep and once he gets up, or once he goes to bed, he is unable to fall asleep continuously, or once he wakes up, he cannot fall back to sleep. So in insomnia disorder, individual often is unable to get restful sleep despite having the opportunity to sleep. So this does not include an individual who has to be sleep deprived because of his work, or somebody who has the kind of work schedule or travel schedule which does not enable him to fall asleep in the night. Here we are looking at an individual who has all opportunity to sleep. He has a bedroom, he has a bed, he has everything available. Despite all of this, he cannot fall asleep. That is, the environment is amenable for sleeping, but he is unable to sleep. Insomnias often lead to significant dysfunction in performance, have negative impact on physical health, with increased risk of developing other comorbidities, medical issues, and often make them vulnerable to psychiatric illnesses such as depression and anxiety disorders. It is also often seen that these individuals also become increasingly prone to addiction to substances such as alcohol and sedative hypnotics in a bid to medicate themselves for getting good sleep. So coming to epidemiology of insomnia, at least 10% of general population suffer some kind of insomnia, and most often 40% of them have anxiety disorder as a comorbid condition. It has been seen that 34% of individuals with depression and other medical comorbidities such as hypertension, diabetes, etc. suffer from insomnia, which often persists beyond the treatment of comorbid condition. That is, if we have an individual with depression, his depression might reduce, but he might continue to have sleep disturbances. Similarly, a person with hypertension or diabetes, uncontrolled, can develop insomnia, but despite getting his medical conditions under control, insomnia continues to be present. It is commonly seen in females and more often in elderly. It increases with age, but however, in younger age groups, it is not uncommon to be found. So when to diagnose insomnia? Should we diagnose insomnia if a person complains of sleep disturbances or insomnia for the last a day or two, or in the last 1 week? No. The frequency should be at least 3 times a week for at least 3 months. And the different types that have been described as per DSM-5 is episodic, persistent, and recurrent. These basically help us to understand and plan the management for a particular individual. Episodic is when the insomnia lasts for 1 month, but less than 3 months. Persistent, duration is longer than 3 months. Recurrent, wherein an individual has had 2 or more episodes within a total period of 1 year. So insomnia is a disorder that can be present as a comorbidity and also independently. So very often we might have individuals coming to the clinics with complaints of just sleep disturbances in the absence of any other medical or psychiatric illness, which is often stated as primary insomnia. Next, coming to hypersomnolence disorder or hypersomnia. Hypersomnia refers to excessive sleepiness, excessive sleep quantity without reduced vigilance or alertness during usual periods of wakefulness. This means the total duration is increased. Person feels the need for excessive sleepiness, but when he is awake, There is no decreased attention or decreased alertness during the time he's awake. Sleep duration is at least 7 hours or more. An individual often experiences what is called a sleep inertia or sleep drunkenness, wherein if the person is woken up before the stipulated period that he or she, his or her body needs. For example, if you have an individual who needs a sleep of 10 hours, if that person is woken up earlier, then he or she experiences what is called as sleep inertia or sleep drunkenness when they're woken up very early, wherein they feel very drowsy. They're unable to start off with their daily routine or other activities. They have difficulty in concentrating. Diagnosis, similar to insomnia, it has to be present at least 3 times a week for 3 months. Etiology for hypersomnia, it seemed there is no clear identified cause, but it has been known to be a result of neurological sleep regulation dysfunction. The common causes that are associated with hypersomnia are neurodegenerative conditions such as Parkinson's disease, Alzheimer's dementia, and certain other neurological disorders. Psychiatric illnesses, it is quite commonly seen with depression. And at times, with certain medical conditions also it is seen, such as thyroid dysfunction also, especially hypothyroidism. And sometimes, and most often, there is no cause identified, wherein it is idiopathic in nature. So how do we diagnose hypersomnia? Hypersomnia is basically, we can diagnose by history and then polysomnography findings. Polysomnography, we shall discuss detail at later part of the presentation. In polysomnography, the sleep latency is short. That is, the period of person going to bed and falling into deep sleep is less than 10 minutes. REM sleep onset is within 20 minutes. Overall sleep duration is increased. And sleep efficiency, that is, total sleep and time in bed is more than 90%. That is, as in when the person goes to bed, he or she goes into deep sleep. What are the differential diagnoses that we need to consider before diagnosing hypersomnia? Obstructive sleep apnea. Usually, polysomnography will confirm the diagnosis. Important here is to differentiate it from narcolepsy, wherein in narcolepsy, the individual has very little control over his sleep, and at times there is difficulty in staying aroused, even though the person puts in a lot of effort in narcolepsy. So this differentiates narcolepsy with hypersomnia. In hypersomnia, the alertness is not affected while the patient is awake, though he is drowsy. Whereas in narcolepsy, he is unable to control his sleep or stay awake despite lot of his self-effort. Next, coming to narcolepsy. What is narcolepsy? Narcolepsy is a sleep disorder which is characterized by recurrent, irrepressible need for sleep in the form of recurrent daytime sleep naps and lapses into sleep. When we say recurrent, irrepressible, this means it happens again and again, and the person is unable to stop himself from going to sleep. Again, the duration and frequency for diagnosis, it has to occur 3 times a week and for 3 months. What is the criteria? Criteria is that narcolepsy, along with recurrent irrepressible need for sleep, there should be at least one episode of catalepsy, which is characterized by sudden loss of muscle tone, usually occurring after a strong emotion such as laughter or extreme sadness or anger. Here, the person is aware and awake, but unable to move. Evidence of hypocretin deficiency in CSF analysis, along with excessive daytime sleepiness and daytime sleep naps. There should be either catalepsy or evidence of hypocretin deficiency for a diagnosis of narcolepsy to be confirmed. Coming to its epidemiology, there is no gender difference in prevalence. It is often heritable. It has autosomal dominant inheritance. Presence of a first degree relative with narcolepsy. increases risk of the individual to develop narcolepsy by at least 10 to 40 fold. It has been known that a halotype HLA DQB 06Z2 allele is present in almost 95% of individuals with narcolepsy. And often it starts in adolescence and continues through adulthood. In some individuals, the illness intensity can decrease, but it often persists. The classic triad that has been described for narcolepsy are excessive daytime sleepiness along with multiple daytime naps, hypnagogic and hypnopompic hallucinations. Hypnagogic is while falling asleep, a person experiences hallucinations, which can be auditory or visual hallucinations. Hypnopompic is while waking up. Catalepsy, like discussed earlier, wherein there is loss of muscle tone with intact awareness and wakefulness. Sleep paralysis, at times wherein there is loss of muscle tone with person being unaware of his surroundings. This classic presentations is very uncommon to be present, and it is seen in very less percentage of people presenting with narcolepsy. So the usual clinical types described are narcolepsy with catalepsy and narcolepsy without catalepsy. So etiology, like in its nomenclature itself, narcolepsy or hypocretin deficiency is there. So narcolepsy is caused by hypocretin deficiency. Hypocretin is involved in regulating arousal, wakefulness, and appetite of an individual. In addition to this, it is also known to influence an individual's motivation, which thus also describes why an individual with narcolepsy not only has a difficulty with his sleep regulation, but also has significant impairment in his functioning. Here, in this disorder, there is destruction of the hypothalamic neuropeptide releasing neurons, which leads to the deficiency of hypocretin. How do we diagnose narcolepsy? Definitely, a good history is very important for diagnosing any sleep disorder. But in addition, polysomnography plus multiple sleep latency tests is the gold standard for confirming the diagnosis. Here, the sleep latency is seen to be less than 8 minutes, and the REM sleep onset is less than 20 minutes. CSF hypocretin levels, which is done through immunoreactive assays, shows less than 1/3 of the baseline or less than 110 picograms per ml of the CSF. So next, coming to the breathing related sleep disorders. This group includes obstructive sleep apnea, central sleep apnea, and sleep-related hypoventilation. This group of sleep disorders are characterized by apnea and hypopnea. Apnea, wherein there is total absence of airflow. Hypopnea, where there is reduction, but there is some airflow occurring. And lastly, the respiratory effort may be variable. There may be some respiratory effort like in hypopnea, whereas in apnea, there may be total loss of respiratory effort. So coming to the clinical features of individual disorders, first the obstructive sleep apnea. The clinical features are nocturnal breathing difficulty, that is difficulty in breathing while asleep, snoring, excessive snoring is seen, snorting is seen, gasping in sleep because of apneic spells. This often leads to significant daytime fatigue, poor unrefreshed sleep, and ultimately impairment in the individual's functioning. Some individuals, when the obstructive sleep apnea is very severe, due to the chronic hypoxia that occurs during sleep, there can be severe cognitive impairment, which often leads to difficulty in concentration and memory. And if this is present, there is an urgent need to address OSA and then provide appropriate treatment. Epidemiology. OSA is known to be one of the common causes of daytime sedation and fatigue in those above 50 years of age. Seen more often in males, more often with individuals with obesity, when there is an increased neck circumferences that is more than 17 inches and retrographic jaw. Increasing obesity means that at least 10% of women over 40 years and 5% of women at present have moderate to severe sleep apnea. So the prevalence of sleep apnea is increasing day by day due to the increasing prevalence of obesity. In children too, obstructive sleep apnea can be seen, especially when they have conditions such as adenotonsillar hypertrophy, and in children with Down syndrome. They can present with OSA very early on in their life. This can be due to structural issues, dysmorphic features such as short neck, and also due to hypotonic muscles. Individuals while on medications, especially those with psychiatric conditions such as depression and psychosis, at times have increased risk of OSA. One, because of the condition and poor lifestyle. Second, due to the medications, especially with atypical antipsychotics, wherein there is increased risk of metabolic syndrome, which increases the risk of obesity and ultimately the risk of OSA. So coming to the diagnosis. A simple validated screening tool, which is called a STOP Bank, is a questionnaire that is widely used both for clinical and for research purposes to help us decide if an individual requires further investigations for confirming the diagnosis of OSA. So as you can see, as the snapshot that I have put here, it has 8 questions. First is the snoring, tiredness, observed apnea, which often is observed by the family member or the bed partner, who could be a spouse or a roommate or any family member who stays in the same room. High blood pressure can be present. BMI, the first part is the stop, then next coming to the bang. B for BMI, body mass index, which indicative of obesity, more than 35 kilograms per meter square. Age, more than 50 years. Neck circumference, more than at least 15.75. Gender, male, as discussed earlier, increases the risk of, with other comorbidities, increases the risk of OSA. So a score of more than 5 is indicative that the individual definitely has OSA risk. Somewhere between 3 to 4 score is intermediate risk. So a person with intermediate risk will require regular monitoring, but somebody with more than 5 is almost indicative that the individual might have OSA. So he or she would require further investigations for the same. So what is the investigation that we need to carry out for the diagnosis of OSA? It is the nocturnal polysomnography, which is the gold standard investigation. So basically, polysomnography measures the nighttime breathing patterns. Apnea and hypopnea episodes are measured. Oxygen saturation in the sleep. And it measures what is called as a apnea-hypopnea index, which is nothing but number of apneas plus number of hypopneas divided by the number of hours of sleep. So at least a score of 5 is needed to diagnose OSA. By the AHI scores, we can also grade the severity of OSA, which is divided into mild, moderate, and severe. Mild, 5 to 14 score, moderate, 15 to 30, and severe, more than 30. So next, coming to the central sleep apnea. We have now finished with obstructive sleep apnea. Now we'll move on to central sleep apnea. Central sleep apnea is characterized by repeated episodes of apnea and hypopneas during sleep, 5 or more such episodes with variable respiratory effort. So like what we saw in obstructive sleep apnea, the respiratory effort is not affected. The person still has some amount of respiratory effort that he or she puts in order to breathe or take in enough oxygen during sleep. Whereas in central sleep apnea, the respiratory effort is affected. What are the different types of central sleep apnea? First is the idiopathic, wherein there is apneas and hypopneas with varied respiratory effort without any evidence of airway obstruction. That is, there is no evidence of OSA or any kind of obstructive features in the upper airway or the lower airway, but the person continues to have apneas and hypopneas. Kind-Stokes breathing, which presents as crescendo-decrescendo variation in the tidal volume of the breathing, that results in central apneas and hypopneas. But here, the hypopneas and apneas are associated with arousal. That is, an individual can become aroused during the time where there is apnea or hypopnea. Another important type or etiology that is seen for CSA is comorbid opioid addiction. It has been seen that opioid has a negative effect on the respiratory rhythm generators in the medulla. This is because of the repeated episodes of hypoxia and hypercapnia that occurs during the person use of opioids, either it could be overdose or during the abuse part, which has in turn effect on the respiratory drive of an individual. So somebody with chronic opioid addiction, they are at increased risk of central sleep apneas due to destruction or damage that occurs due to the repeated hypoxias and hypercapnia to the respiratory centers in medulla. Comorbidity, heart failure is quite common comorbidity that occurs with CSA. It is more prevalent in individuals living in higher altitudes. The age group presentation can range from middle age to elderly. As mentioned earlier, 30% of those with opioid addiction on methadone maintenance therapy have CSA. This is basically an indicator of individuals seeking help, but there could be many more who are not seeking help or treatment for their opioid addiction. Diagnosis is confirmed by polysomnography, where there are episodes of apneas and hypopneas in the absence of other features of OSA. Lastly, among the breathing related sleep-wake disorders is the sleep-related hypoventilation. Sleep-related hypoventilation is characterized by episodes of decreased respiration associated with increased carbon dioxide levels, not explained by other sleep disorders. It can be idiopathic and manifests in adulthood. The different variants that have been described are congenital central alveolar hypoventilation, which is a rare disorder, presents in perinatal period, wherein the infant can present with shallow breathing and cyanosis. Comorbid sleep-related hypoventilation, wherein comorbidity such as COPD, interstitial lung disease, and muscular dystrophies, which affect the respiratory effort of the respiratory muscles, can lead to sleep-related hypoventilation, wherein the respiratory drive or the effort decreases in sleep. Some medications such as benzodiazepines and opiates can also cause sleep-related hypoventilation. Next, coming to the next broad category, that is the circadian rhythm sleep-wake disorders. Circadian rhythm sleep-wake disorders are characterized by alterations in endogenous circadian rhythms, and they are required physically, socially, and professionally determined sleep-wake schedule, leading to insomnia and daytime effects. It is basically acquired, wherein the individual alters the sleep-wake his or her own sleep-wake cycle, which does not follow the normal sleeping pattern. And this could be driven by the physical need for it, social need, wherein it could be because the social circles engage more during the night, or somebody in professional requirements, such as somebody working in shifts, or somebody who requires to work from home in the night hours like we see now during the COVID era. So many of these individuals and professionals who have had to change their working patterns are suffering from circadian rhythm sleep-wake disorders. So the different types are episodic with recurrent, more than 2 episodes, and persistent, wherein there are persisting more than 3 months. So what are the different types of circadian rhythm sleep-wake disorders? First is the delayed sleep phase type. General population, it is seen about 0.17%, more commonly seen in adolescents, wherein sleep is delayed beyond the socially accepted bedtime. Most often, in most households, everybody is expected to go to sleep at around, say, 9 o'clock. But here, an individual pushes the sleep time to, say, 12 o'clock or 1 o'clock. So this is delayed sleep phase type. Advanced sleep phase type, sleeping early and waking up early. Here, the sleep duration is normal. For example, a person may sleep, say, about 6 o'clock in the evening, but wake up by 3 o'clock or 2 o'clock in the morning or early in the night, late in the night. So here again, the sleep duration is normal. The sleep quality is also within normal limits. Irregular sleep-wake type, wherein there is disorganized sleeping patterns with numerous naps, no continuous or fixed sleep time. Here, basically, an individual takes short naps, maybe half an hour, 1 hour naps through the day and night, but never have a continuous sleep that we would norm, that is about 6 to 8 hours of sleep that is needed, continuous sleep, that is not followed by this individual. Lastly, non-24-hour sleep-wake type, wherein sleep is not synchronous to the day and night. Here, they may sleep during the day, but stay awake in the night. And this is often seen with individuals with severe visual impairment, individuals with complete blindness, where there is no light and dark stimuli, alternating light and dark. So therefore, they fail to follow the normal circadian rhythms. Lastly is the shift work type. As the name suggests, it is seen in individuals who have shift works, where they have to work during the night, and often these rotations continue. It is seen about in 5 to 10% of night shift workers, and about 16 to 20% of the total workforce have suffer from some type of shift work type of sleep disturbances during their work period. Next, coming to parasomnias. Now we have completed the circadian sleep disorders, clinical features. Now coming to parasomnias. Parasomnias are basically characterized by abnormal behaviors in sleep. So here we can divide them into NREM sleep disturbance parasomnias and REM sleep parasomnias. So NREM includes sleepwalking and night terrors. As discussed earlier, the person goes into deep sleep. Here, he or she is unaware of the external surroundings. The brain activity becomes almost very minimal. So here, NREM sleep parasomnias usually start in childhood, decreases as one grows older, and its prevalence may range from 1 to 7% in adults, and in children very high, up to 10 to 30%. Very often family history is present, and in some individuals sleepwalking can be hereditary, wherein it has autosomal dominant penetrance in the chromosome 20. It has been seen that wherein even though a person is a carrier, this disorder can skip generations. Somebody who has sleepwalking, his immediate progeny or children may not develop the sleepwalking disorder, but the children's children or the grandchildren of the index individual can develop sleepwalking disorder. So at times this can skip generations. Next, coming to the REM sleep parasomnias, nightmares and REM BDs. Nightmares are basically characterized by vivid dreams in which individual remembers, wakes up from sleep in intense anxiety with autonomic arousal, common in childhood. As you can see, we have night terrors in NREM sleep parasomnias, and nightmares in REM sleep parasomnias. What is the difference between the two? In NREM, there is a bad dream. The person might get up shouting or fearful, but then he or she would not remember the dream that they've had just then. Whereas in nightmares, which is a REM sleep disturbance, parasomnia, they do remember the dream and are able to vividly describe what the dream contents are. Coming to REM BD. Here, there are complex motor movements in sleep, such as a person could be pushing, cycling, at times fighting in sleep, but is unaware that he or she is doing such activity. Here, it can be seen in individuals with neurodegenerative conditions such as in Parkinson's, dementia with Lewy body disease, and multisystem atrophy. It has been seen wherein alpha-synucleinopathies have increased risk of REM BDs in them. Certain drugs such as tricyclic antidepressants, SSRI, that is selective serotonin reuptake inhibitors, and beta blockers can precipitate REM BD. So sometimes when we're giving medications for psychiatric conditions, such as depression or anxiety disorder, the person can come back and present with sleep disturbances. So this has to be noted that if a person has been prescribed these medications and comes back with a complaint of such sleep disturbances, it has to be taken note, and maybe if it is distressing, the medication would have to be changed. Lastly, last category that we are going to be discussing is the movement-related sleep disorder. This includes the restless leg syndrome and the periodic limb movement disorder. Restless leg syndrome, it is quite commonly seen where there is irresistible urge to move the limbs, and the person feels better on moving, which can be momentarily person may feel better, or permanently the symptom might reduce. It is seen mostly in night when the person is idle and not doing any work. What are the predisposing factors? Female sex, older age, and very commonly seen in pregnancy, especially in the third trimester. For diagnosis, it has to be similar to other group of disorders that we discussed, 3 times a week for at least 3 months. Next, coming to periodic limb movement disorder. It is characterized by moving extremities in sleep. It is an NREM sleep disorder wherein the individual is unaware of the movement he is carrying out during the sleep. It is often associated with daytime sleepiness. 4% of adults and in elderly the prevalence increases. Comorbid and medical and psychiatric conditions are common, and it often leads to significant social and occupational dysfunction. Now, with this, we come to the end of the part 1 of the presentation, wherein we discuss the different classificatory systems of sleep disorders and the broad clinical features of each group of disorders in brief. Now, moving on to the evaluation and management. First, coming to the evaluation, which includes identification. So whenever we come across an individual coming with sleep disturbances, a sleep history has to be taken. A comprehensive sleep history is almost enough to diagnose the type of sleep disorder. Investigations such as polysomnography, which we have discussed in the previous set of slides, are usually carried out for confirmation of a particular diagnosis and for planning treatments. While obtaining history, it is always important that not just from the patient, but information should also be obtained from the person living with the individual, who's the sleep partner or the bed partner, who lives with the patient and who's likely to be the direct observer of any abnormal behaviors in sleep, such as in parasomnias, obstructive sleep apnea, wherein the snoring and the apneas can be identified by the bed partner. So what are the things to be taken in a sleep history? First, What are the chief complaints? What kind of sleep complaint does the individual come with? Does it include daytime sleep complaints such as increased sleepiness, fatigue, heaviness of head, or nighttime complaints such as decreased sleep, repeated awakening in sleep, not feeling refreshed after waking up, or any abnormal behaviors such as in parasomnias and OSA? How the sleep disturbances started, the onset, and the total duration of the complaints. What is the frequency in a month or a week? That is very important. And specific questions that need to be asked are timing of sleep. At what time do you go to bed? Duration of sleep on a given night in hours. So say about last 1 week, what was the duration of your sleep? Did you sleep for 6 hours, 7 hours, or 8 hours? Any daytime naps? Very important. If somebody is napping through the day or has long naps and continues to have sleep disturbance in the night, that is something that we'll need to address. Sleep patterns and weekdays and weekends. Very often, somebody who has been sleep deprived. For example, we were discussing about circadian rhythm sleep-wake disorders. Sometimes, for some individuals, such sleep patterns can be a norm. Some people can deprive themselves of sleep on the weekdays due to work pressure or due to the job schedule, and on weekends they tend to catch up on the sleep. So therefore, the sleep patterns can change during your weekdays or the working days, and on the weekends and holidays. So it's important to check about that as well. Quality of sleep, whether one feels refreshed or not after going to sleep. Again, after sleeping, any daytime fatigue, tiredness, or feeling sleepy through the day. So these are the 6 questions that it is important while taking a sleep history. So once we have got the sleep history, it's always a good idea to know more comprehensively as to what the sleep patterns of that individual are. So in continuation with that, we'll need to ask about the medical history. Comorbid conditions, like we discussed before, such as psychiatric conditions and medical conditions, are quite common with sleep disorders. So checking for medical issues such as hypertension, diabetes, thyroid disorders, cardiac illnesses, respiratory illnesses such as asthma, COPD, obesity is required. Psychiatric history, look for mood disorders such as depression, anxiety, or severe mental illnesses such as psychotic disorders, bipolar affective disorder, and very importantly for substance addiction. Substance addiction can be a consequence of sleep disorders or can itself be an etiology for the sleep disorder. So it's important to check for substance addiction in all individuals presenting with sleep complaints. Medication history. If a patient is taking regular medications or recently started any new medications, it has to be asked. For example, psychotropic medications such as benzodiazepines, antipsychotics, and certain antidepressants such as amitriptyline, escitalopram can cause sedation leading to excess sleep and hypersomnolence. Beta blockers can cause at times insomnia, and like discussed just few slides before, REM-BD can be seen with beta blockers. Tea and coffee. Excess tea and coffee use is, with some people might assume it to be a norm, but if somebody has been taking excess tea and coffee, it can lead to insomnia. As we are aware, tea and coffee are stimulants. So if there is a continuous dose of stimulant being given to the brain, it is unlikely that the person will be unable to fall asleep. Next, coming to the personal history. In personal history, occupational history is very important. What are the hours of job? Type of job? Does it involve shifts? Frequent travel within and across time zones, especially important for jet lag. And occupational stress, which again can lead to psychiatric morbidity, which in turn can lead to sleep disorders. Social history, what kind of relationships he or she has with friends, who are his peers, what kind of activities that one does with the social circle. Substance history, it has to be asked without fail because tobacco and alcohol are one of the most common comorbid conditions that are found with sleep disorders. Tobacco use, it can be smokable in the form of BD and cigarettes or chewable tobacco products. In such people, insomnias are known to be seen. Alcohol use disorders, difficulties can range from hypersomnolence due to intoxication to insomnia during withdrawal period. So both of this have to be asked whether or not the information is offered by the patient. Other drugs such as abuse of sedative hypnotics, such as clonazepam, alprazolam, diazepam, it's very common. Cannabis use and opiates, like we discussed earlier. Opiates themselves can lead to several sleep disorders such as central sleep apnea. Coming to the examination. Examination is one of the important part of our sleep disorder evaluation. Check for body mass index, vitals, pulse, blood pressure and respiratory rate. Systemic examination to look for any systemic issues. In addition to it, a detailed ENT examination, especially when OSA is being suspected. Mental status examination is very vital, checking for the person's mood state, whether he or she is depressed or anxious. Very often, mood is considered to be a vital sign along with the other vital signs such as pulse, blood pressure, temperature, respiratory rate. So it is considered as the fifth vital sign now. So always check for the person's mood state when a person comes with complaint of sleep disorder, because sleep disorders can themselves be manifested with psychiatric disorders, and psychiatric illnesses can present with sleep disturbances. So next, coming to the assessments. What are the assessments that one can carry out? So an important and an easy method is the sleep diary. Here, as you can see, in a sleep diary, ideally you take it for a pattern of sleep pattern for 2 weeks. The individual has to document the sleep pattern as per given in the diary in the morning and sleep diary in the night. So sleep diary morning, basically what he or she did through the day. So the person has to write this at the end of the day. Sleep diary in the night. So basically the person, sleep diary in the morning, he will take down the sleep pattern in the night. Whereas in the night, he will write what he did through the day. For example, in night, he will take down, if at all, one has taken a nap or not, how much caffeine has been taken in the form of tea, coffee, chocolates, anything, any exercise that has been carried out through the day, medications, did I feel drowsy during the day, how was my mood overall, and then what was the time of my bed, me going to the bed, along with that, what were the activities that preceded bedtime. So these are the things one has to write down as before going to bed. So whereas in sleep diary in the morning, so as soon as the person wakes up, once he refreshes himself, he has to write at what time went to bed, what time I woke up, how many hours did I sleep, did I take, how much time did I take to fall asleep, what was the quality of my sleep, did I feel good, no, or bad, very bad, or it was very good sleep. How did I feel in the morning? Did I feel refreshed, tired, groggy, or alert? And were there any issues that made my sleep disturbed, such as the temperature of the room, the noise in the surroundings, any dreams? Was I worried, or there were any thoughts that were disturbing the sleep? Not feeling tired and experiencing discomfort. And during the night, did I wake up many times? So this is the sleep diary. Sleep diary is very easy and can be carried out anywhere without any access to technology also. And this can be explained even to a person who's not very educated. Even with basic education, this can be explained, and it can be translated and used to the person's local language also. So next, coming to the other investigations or assessments that we can carry out is the actigraph. As you can see, this is the a few pictures of actigraphs that are available in the market. Very similar to the smart band or the fit bands that most of us use today. But this is slightly different. Actigraph basically measures the sleep patterns, the circadian rhythms, and at times also the amount of light exposure that is there around the person. It is useful to diagnose insomnias, hypersomnias, and the circadian sleep-wake disorders. So it gives accurate information about the sleep patterns, and usually it is worn on the non-dominant hand. If a person is a right dominant person, he should wear it on the non-dominant hand. And again, to specify here, it is not similar to a fitness band. Most fitness band are able to give information about the sleep timings and the sleep hours, but it does not give enough information about the pattern or exposure to light like we described as much as an actigraph. So actigraph is a very non-invasive, easy method where the person can just wear it and carry it around through his daily routine. Next is the polysomnography. So as you can see, that we have discussed over the last many slides that we have discussed about clinical presentations, polysomnography is almost considered as a gold standard for diagnosis of many sleep disorders. So what does polysomnography do? So polysomnography, as you can see in this picture, polysomnography measures the airflow. It has EEG scalps to measure the brain activity. ECG leads are there to check for the heart rate variation. Pulse oximeter for oxygen saturation levels. Yes, and it also has the elastic belts around the chest and the belly to measure the effort, that is respiratory effort, that is carried out during the sleep time. Most often it is carried out in a sleep center, and if needed, video recording is also carried out if parasomnias and sleep movement disorders are suspected. PSG is not only have a diagnostic value. Say if a person has OSA, then it also helps to titrate the pressure of a CPAP machine so that OSA is treated adequately. So this is a typical polysomnography record that is displayed here. It basically gives a blood oxygen level, the breathing pattern, as you can see where the dip occurred, and what happened to the other sleep patterns. Here we can see the REM sleep pattern, which has been identified through the EEG leads. Yes. So next test is the multiple sleep latency test, which is actually carried out in conjunction with the polysomnography. It measures the level of sleepiness used for the diagnosis of hypersomnias and narcolepsy. It is carried out usually during the day, wherein the separated by 2 hours. So the sleep latency is carried out, measured as to how quickly the person falls asleep. So, and where the sleep nap is occurring, whether the naps are occurring in REM stage or NREM stage, that is also measured through this multiple sleep latency test. Next is maintenance of wakefulness. This is again used for hypersomnias and narcolepsy, aims to measure the level of alertness and the individual's ability to stay awake. Now, lastly, coming to the management. So in management of sleep disorders, the first important main thing, especially when we are talking about insomnias, hypersomnias, circadian rhythm, sleep disturbances, is that the behavioral modification of the individual's daily routine and his own practices, his own knowledge, attitudes, and practices towards his sleep is very important. Whereas in organic or the actual causes such as in OSA, in narcolepsy, along with CSAs, central sleep apnea, parasomnias, medication take predominance along with non-pharmacological interventions. So first and most important, especially when we are talking about sleep disturbances, is the sleep hygiene. This is very important. It is probably one of the most important treatment options that are there for sleep disorders. They're easy to follow, do not involve any interventions. It basically involves behavioral modification of the individual daily routine. So first, use the bed only to sleep, avoid caffeine or any kind of stimulants through the day, practicing relaxation exercises before bedtime, such this could be deep breathing exercises or yoga. Exercise, preferably late in the evening, avoid cardio exercises or aerobic exercises immediately before sleep, preferably at least 2 to 3 hours before sleep. Maintenance of regular schedule of bedtime and nap times if needed. Always avoid daytime naps if one has already sleep disturbances. Do not watch the clock while in the bed. This is one important tip you can give to a patient, is that never look at the clock if you are having already sleep disturbances. Go to bed when you fall asleep and never sit in a bed and wait for yourself to get sleepy. So other non-pharmacological interventions for OSA definitely involves weight gain, targeting the weight gain through exercise, diet control, and the use of CPAP. Surgical interventions such as bariatric surgeries, etc., may be needed for somebody with severe morbid obesity. And in some individuals where the OSA is significant and CPAP is ineffective because of significant airway obstruction, tracheostomy is also carried out so that invasively breathing can be facilitated. For sleepwalking, the drugs are partially helpful, but prevention is what is important. Prevention in terms of preventing hurt to others or to self through locking the doors, locking the windows, always having somebody around in the vicinity where the person sleeps, and preferably take away all the objects such as knives, loose clothes around the individual for preventing any harm to self. In circadian rhythm sleep-wake disorders, light phase shift therapy is something that has been useful, wherein a person is, when there is difficulty in falling asleep, which can be due to jet lag or shift work, exposure to bright light during the time one stays awake, or if somebody has difficulty falling asleep in the night despite working during daytime, exposure to natural light is also helpful to normalize the sleep schedule. For insomnia, in addition to the sleep hygiene and other techniques, behavioral therapies such as cognitive behavioral therapy to address their myths and their misconceptions about their own sleep. Some person's perception might be that I have to sleep for 10 hours in a day, or continuously worries, even say a person sleeps for 6 hours, but the person continues to be preoccupied by the sleep disturbances. CBT helps to address these misconceptions and their negative thoughts about their sleep patterns. Pharmacological treatments. Medications are often used as adjunctives, especially for insomnias and circadian rhythm sleep disorders. All factors should be taken into account before prescribing medications such as comorbidities, risk of abuse, and also affordability. Treatment of comorbid conditions is important while treating sleep disorders. If somebody has thyroid dysfunction, along with sleep, thyroid dysfunction has to be treated. Obesity, dyslipidemia if present, that has to be addressed. If depression is there, depression has to be treated. And if somebody has addiction related issues, along with sleep, addiction related problems have to be addressed. If not, the sleep problem will not resolve. So medications for insomnia, benzodiazepines are very commonly used, prescribed over the counter at times, but recently it has become quite regulated in view of significant abuse by people, addiction potential, and misuse by pharmacies. So therefore it is regulated now. Short-acting drugs such as etiozolam, alprazolam are usually used for inducing sleep. Long-acting diazepam, clonazepam, nitrazepam are used. And the utility for sleep disorders is that they shorten the sleep onset latency, decreases the number of nocturnal awakenings, especially with long-acting benzodiazepines, reduce time spent awake, and overall subjective improvement in the quality of sleep. So again, it is to be noted that These have to be used only for a short period. Anything beyond 2 to 3 weeks, always caution about addiction has to be taken care of. At times, this addiction problem can be induced wherein the person can abuse the prescription medication, leading to difficulty in withdrawing the drug itself and developing an additional addiction problem because of benzodiazepines. And in elderly, when prescribing for sleep disturbances, always take a precaution to avoid benzodiazepines as much as possible, because there is increased risk of sedation and then falls. Next is the non-benzodiazepine derivatives, which are commonly used are zolpidem and zopiclone. Here, they again cause a reduction in the sleep onset latency, less number of nocturnal awakenings, and increased total sleep time. They have known to have less potential to addiction, but again, on chronic use, dependence or addiction can be there. And they're also known to be less sedating in terms of causing adverse effects. But however, in elderly, it has to be used with caution. And other advantage is that for somebody with say perioperative period, or when sleep has to be addressed in a just for a short period, zolpidem and zopiclone like drugs are quite useful. Next is the melatonin and ramelton. As we know, melatonin is a sleep hormone. So synthetic melatonin or ramelton, which is a molecule of melatonin, similar to MT1 and MT2 acting on MT1 and MT2 receptors. These are beneficial, and this is helpful in sleep onset. It basically causes fatigue and sleepiness, leading to getting a person to fall asleep. Prolonged release preparations help to maintain sleep as well. Lesser risk of addiction, can be used safely in chronic insomnia, even in elderly with neurological conditions. And it is also known to be helpful in REM behavioral disorders. Certain antidepressants, along with antidepressants for use of depression, certain antidepressants such as trazodone, mirtazapine, are used at low doses for sleep disorders. They help in sleep maintenance and treatment of the comorbid depression as well. Over the counter, many other drugs are used, such as antipsychotics, quetiapine. Low-dose antipsychotics are often also prescribed for sleep disturbances, but again, they need to be used with caution. So what are the other medications that can be used for sleep disorders to promote wakefulness and arousal? For excessive sleepiness, caffeine is used, but again, like we have discussed, excessive caffeine use itself can lead to insomnia. So therefore, it has to be used with caution, or advice has to be given with caution. Modafinil and R-modafinil are wakefulness promoting drugs, are used often in narcolepsy and hypersomnias. Stimulants such as methylphenidate are helpful again with individuals with narcolepsy. Tricyclic drugs, which have anticholinergic property, have been shown to be beneficial with individuals with catalepsy, which occurs with narcolepsy. Sodium oxybate or gamma hydroxybutyrate. It is a gamma hydroxybutyric acid B subtype, which is GABA B receptor agonist, approved for the use of catalepsy in adult. It is currently an orphan drug and is not easily available. It is approved for adults, but children it is not to be used at present, and it is one of the recently approved FDA drugs. So these are the brief overview of the medications that are used, but there are several other drugs that are prescribed, but these are the few FDA approved or approved drugs that are used for promoting wakefulness and arousal. Summarizing what we have discussed today, sleep disorders, like mentioned, it is very common. 10% of general population have some type of sleep-wake disorder, and most common is insomnia. Medical and psychiatric comorbidities are very common. While evaluating for sleep-wake disorders, history is very important, and it has to be taken both from the patient and the partner. Investigations such as polysomnography are used for confirmation of diagnosis in conjunction with assessments such as sleep diary. Management, non-pharmacological interventions are important, along with medications which are to be used for short period, especially if being treated for insomnias. For disorders such as narcolepsy, OSA, prolonged pharmacological interventions are required, and may have to be continued for a prolonged period of time, even for many years. So references and further reading: Comprehensive Textbook of Psychiatry by Kaplan and Sedov and New Oxford Textbook of Psychiatry can be used as references for your further reading. Thank you.